Welcome everybody to our latest edition of our Lunchtime paper presentation series. We're gonna give everyone just like a couple more minutes to join in the meeting, and then we'll have Kelsey introduce our speaker, and then we will have our presentation. Um, since this is a Zoom Zoom meeting and not a webinar, you can see everyone's here. You can use the chat during the Q&A session. You can raise your hand and unmute and ask questions. Feel free to do that. So we want this to be a pretty interactive kind of space. Just note we are recording the session and it'll be up on our website in a couple days.
Awesome. Thanks, Judith. How about if I get started and people can
Yeah.
come in? My name's Kelsey Chalmers. I'm the Senior Director of Research at the Loud Institute. And I have the pleasure of introducing Michal Horný to you today. Michal and I met recently at the Academy Health Conference in Seattle. We were both interested in out-of-pocket costs, and Michal had a really interesting poster that he's going to talk through some of it today with you. So Michal is a health services researcher and health economist at UMass Amherst. His research aims to improve the affordability of healthcare for those in the United States. He studies the factors that shape patients' exposure to the cost of care and evaluates the implications for patients' health and their finances. And his current work includes investigating the impact of recent federal price transparency regulation, the financial risks that patients face due to the uncertainty in the service composition of healthcare episodes. And what we'll hear about today is the affordability challenges that are driven by the temporal concentration of medical out-of-pocket costs. And just before I hand it over, I think we have a plug for our next webinar as well. So at the end of this month, we have another guest speaker who's going to be talking about revenue cycle management within hospitals and how this can get outsourced, especially if hospitals are taken over by private equity. So with that, I'll hand it over to Michal.
Thank you so much for this lovely introduction, hi everyone. Thank you for joining this webinar, this meeting. I generally like for my presentations to be interactive. So if you have any immediate questions, feel free to interrupt and ask. But otherwise, I suppose we will have questions at the end. So with that, let me figure out if I can share my screen. All right, how does this look? Do we see the
Yeah, looks great.
the slides? Good.
Mm-hmm.
Let me slightly rearrange this so that all right. Okay, but let me start. Well, let me say, so today I'm going to talk about my working paper. It's still work in progress, so please take everything with a grain of salt. It's about the timing of out-of-pocket costs and affordability of healthcare. This is joint work with my wonderful co-author, Katie Lott. And let me show you some of my disclosures. This project was partially funded by the National Center for Advancing Translational Sciences from the NIH. Thank you for that. And some of my other disclosures are on the slide. So let me start with a background. I somewhat assume that everyone who has joined already knows that healthcare in the US is incredibly expensive, and the affordability of healthcare is a major concern for large portions of people in the US. And overall, like affordability of healthcare is, therefore the affordability of healthcare is a topic that many health economists study. But what I've seen so far is that most studies or most research on the affordability of healthcare uses annual measures of, on the one hand, disposable income, and on the other hand, the annual measures of healthcare costs. And but given that most of us experience the economy, on a continuous, maybe monthly basis, then these annual metrics can obscure some of the challenges that people may face. What I mean by this is that household cash flow tends to be somewhat regular, of course, like not perfectly regular, but most of us pay rent or mortgage payments every month, phone bills, utility bills. All of these payments are on a monthly basis. At the same time, people usually are paid income on a monthly basis, maybe biweekly. That is the case even for Social Security payments that people who are retired receive, and so on. But on the other side of the equation, we have healthcare costs, and those are often, or those may be and tend to be clustered in time. There are two key mechanisms for this. One is the fact that the healthcare needs are sometimes clustered in time. It can be a heart attack, it can be an accident. But even for people who have fairly like regular and predictable healthcare costs, such as people with chronic conditions, their costs can still be well, people who have predictable healthcare needs, that's what I meant. Their costs can still be clustered in time due to nonlinear health insurance contracts, such as health insurance plans with deductibles that cluster or expose patients to higher costs at the beginning of a policy year, and then over time those costs get lower. So with this, I believe that temporal concentration of out-of-pocket costs is an understudied aspect of healthcare affordability, and we're trying to shed more light into it. So overall, our objective is to characterize temporal concentration of out-of-pocket costs to see what is actually happening, and assess the extent to which the temporal concentration contributes to broader healthcare affordability challenges. Maybe to put this in more layperson's terms, what we expect is that that temporal concentration may matter only for certain amounts of annual out-of-pocket costs. In other words, if someone's annual out-of-pocket costs are incredibly high, let's say, if I exaggerate $100,000, that amount will most likely be unaffordable to most people. It doesn't matter how concentrated or spread out it is. On the other hand, if annual out-of-pocket costs are really low, $10, $20, again, it probably doesn't matter how concentrated or spread out that amount is. It will most likely be affordable to most. But there probably is some area somewhere in the middle where costs can be a given amount can be affordable if it's spread out over time, but it can be unaffordable if it happens all at once, one bad day, one bad week. And we're trying to investigate, like where the line is, where costs, healthcare costs start to be unaffordable. So overall, for the research design, we're currently using data from the Medicare Current Beneficiary Survey with cost supplement. It's a national representative survey of Medicare beneficiaries. Eventually, we plan to expand this analysis to and use MAPS data, the Medical Expenditure Panel Survey data, that would include other populations, not only those covered by Medicare, but for now we're using this Medicare survey. What's cool about it is that not only it's a national representative survey, but it also links up to 5 years of claims for those individuals who are enrolled in traditional Medicare. So as you probably all know, roughly half of people, Medicare eligible individuals, are covered by Medicare Advantage, and we do not observe claims for them. We observe claims only for the half of Medicare eligible individuals who are covered by the traditional Medicare. And we also restrict the sample to those who are continuously enrolled for at least 2 years, and that is for a particular reason. So I said that we're using 2023 data, 2023 survey. So if we're in 2023, people were asked the question whether they had problems paying medical bills in the past year. They're asked this question in early 2023, usually between January and April. And so when they're asked this question, they of course think about, their healthcare spending patterns in 2022, the year before. And so we need to make sure that we observe not only the individual, not only the responses, but also the experiences with healthcare costs. Then for the for the model, it's at this point it's purely associational, fairly simple logistic regression model where the outcome is having problems paying medical bills, and we model this probability using annual out-of-pocket costs, the annual amount, the temporal concentration of that amount. I will speak about that in a bit, in a bit more detail, how we actually measure that. An interaction so that we can see whether the temporal concentration modifies the effect of the overall amount of out-of-pocket costs on on affordability challenges, and we control for income. So let me now take a quick sip, and I'll now move to another section of my talk about how we actually measure temporal concentration. All right. So our key innovation here is that there already are several metrics of concentration. You probably have heard of the Herfindahl-Hirschman index or a Gini coefficient. And these two metrics are used to measure concentration of some quantity. HHI, the Herfindahl-Hirschman index, is usually used to measure the level of competition or market share of firms in a market, while Gini coefficient is often used to measure concentration of wealth in a society. And both these metrics use categorical support, meaning that firms in a market or individuals in a society are categories at a given point in time, right? And but if we applied these metrics to healthcare spending patterns, we would ignore the order in which costs are accumulated over time. And we would also ignore the temporal distances between them. You can think of this if someone received, 10 medical bills, each for about $100. Both Gini coefficient and Herfindahl-Hirschman index would conclude that this is, very equally spread cost burden. But if those $100 bills, if all 10 are received within 1 week, that can be a significant burden, that is concentrated in time. And so we developed a metric that accounts for this. I will not go through all the details here. I will just quickly mention that we measure both time, like when costs were incurred, and the amount of those costs, and we measure both on a relative scale. So the times. So for example, if our focal time interval is 1 year from January 1st to the end of December, if someone incurred costs on July 1st in the middle of the year, the value TI would be 50%. It was in half of that interval. Same thing, the PI is a relative contribution of each medical bill to the overall aggregate out-of-pocket cost burden. So if someone incurred $1,000 in medical out-of-pocket costs over the course of the year, a medical bill for $100 would contribute 10%. That's the key idea here. And when we designed the metric, we took a lot of inspiration from the design of the Gini coefficient. I don't know how everyone like knows how well everyone knows how the Gini coefficient works, but it relies on a function called Lorentz curve that essentially orders all individuals in a society from those with the lowest income to the highest income, and then compares the shape of this curve to a curve if everyone's wealth was the same. And the ratio of these two curves is the Gini coefficient, essentially. So we do something similar here. It's more complex, and I will not go over the details too much. We don't really have time for that. But in a way, this is a generalization of this function is a generalization of the Lorentz curve, where we essentially scan the whole aggregate function of out-of-pocket costs, and we look like where it was steepest, where most costs were incurred in a very short period of time. So this allows us to put some structure on the patterns of out-of-pocket costs over the course of the year. Then ultimately, our temporal concentration index looks like this. Again, I will not explain everything, explain this in detail. What I want you to take away from this is that overall, or theoretically, it can range from 0 to 1. And 0 means a perfectly steady flow of whatever outcome you're measuring. In this case, it's out-of-pocket costs. This would mean essentially, a penny every second, something like this, steady flow of costs in very short time intervals. While 1 means that the entire cumulative outcome, so entire annual out-of-pocket costs, would be incurred in just a single event. And anything in between is, anything in between. Those are the two extremes. All right, so let me now dive into the more interesting part. That's the empirical analysis. So as I said, we're using 2023 Medicare current beneficiary survey with a cost supplement. We restrict to those enrolled in traditional Medicare and those continuously enrolled for at least 2 years. The 2023 sample description is here on the right-hand side. There's nothing too interesting. We have Medicare beneficiaries, so the individuals are older. There are more women than men, as in the broader population, because women tend to live longer. What I want to point out is that of the individuals who were surveyed in 2023, about 94% were observed for the whole year. And we're using those who are enrolled in for the entirety of 2023 to gain insight into, to characterize temporal concentration. But then we use those who were enrolled in the current and the prior year to measure the association between or the effect modification of temporal concentration of costs and the how it modifies the effect of the annual amount on affordability challenges. All right, so let me start with some histograms. The left column is for healthcare spending. So those are the amounts that Medicare paid to healthcare providers over the course of the year. The right-hand side are out-of-pocket costs. I will focus mainly on out-of-pocket costs because that's the main topic of this talk. So the blue histogram shows the distribution of annual out-of-pocket costs in the Medicare population. This is nothing new. If you study costs, you've probably seen a version of this histogram before. Healthcare costs and out-of-pocket costs tend to be highly skewed to the right. Here, I just want to point out this spike at the very end. This is due to top coding. This is artificial. there are very few people with very, very high costs, and it wouldn't all fit on the slide. So this spike is artificial, but overall, like this histogram is not surprising. What I want to talk mainly about is this orange histogram in the bottom right cell. That is the histogram or shows a distribution of the temporal concentration of annual out-of-pocket costs. And what I find fascinating here is that it very much spreads the whole interval from 0 to 1, meaning that there's no typical pattern, typical temporal pattern in which Medicare beneficiaries incur their annual out-of-pocket costs. For some of them, they're fairly spread out. For others, they're very concentrated. Unlike in the top histogram, when the spike at the right end was artificial, here it is not. This spike here at 1 means those are individuals who incurred their like all annual out-of-pocket costs in just one event, one day. Um, then we looked at the joint distribution of the annual amount and the temporal concentration. Again, I will be focusing mainly on the right, on the figure on the right here. So here on the vertical axis, we have temporal concentration, 1 meaning highly concentrated, 0 meaning perfectly spread out. And on the horizontal axis, we have annual out-of-pocket costs. And as you would expect, individuals, let me start here in the top left corner. Individuals who incurred very low amounts in out-of-pocket costs, $20, $50. It probably happened in just one event, or it was very concentrated in time. But as we get to higher amounts, the concentration gets lower, meaning that higher amounts typically tend, more time to accumulate over time. Again, not too surprising. I don't know if you can see it, there's like a little cloud here at about $3,000 in out-of-pocket costs and fairly high concentration. Those are people with hospitalizations. The hospitalizations are concentrated in time and very expensive. And then for those people who had very, very high out-of-pocket costs, again, top coded at here $5,000, there are all kinds of experiences. Some people incurred those costs right away. For some of them, it took the entire year to get to those amounts. Given that we developed the temporal concentration metric, you can be you may not be convinced that this is actually measuring what we think it's measuring. So we ran a few associations or correlations to validate the metric that it measures what we think it measures. So first we correlated the temporal concentration index of spending. So now I'm moving away from out-of-pocket costs for a moment because out-of-pocket costs are a function of not only spending, but also benefit design. So now I want to focus only on spending, which measures is a better approximation of healthcare needs. And what we expected to see is that as people get older, they're more likely to have more chronic conditions, long-term healthcare needs, and their spending would be more spread out, as opposed to younger individuals would have more ad hoc healthcare needs, and therefore their spending would be more concentrated. And that's exactly what we see here. So that gives the metric some credibility. Then we correlated temporal concentration index of spending with self-reported health status. And again, as we expected, people with excellent health, self-reported or self-assessed health, report or experience most concentrated spending, while those in fair health have spending most that is most spread out. This pattern is not perfectly monotonic. Like there's for those individuals who said that their health is poor, their spending seems to be a little more concentrated than for those assessing their health as fair, which we interpret as those individuals who would rate their health the worst, they probably had some health incident, heart attack, accident, and therefore their spending is more concentrated. Overall, again, like this to me is it provides some credibility to the metric. Finally, we looked at the temporal concentration of annual spending by presence of of a chronic condition. We focus on the most common chronic conditions in this population, and each of these is essentially the difference in temporal concentration of spending between people with a given health condition compared to those who don't have it. And as you can see, all of those differences are negative, meaning more spread out healthcare spending over the course of the year. Again, that's what we would expect. People with chronic conditions get healthcare more frequently in a more regular pattern than those without those conditions, right? So all of this taken together gives me gives me faith that the metric is measuring what we think it's measuring. So and now let me get to essentially the main finding of our paper so far. When we look at how temporal concentration of out-of-pocket costs modifies the association between the out-of-pocket cost amount, the aggregate annual out-of-pocket cost amount, and having problems paying medical bills. Let me start focusing on the lowest spenders, or individuals with the lowest annual out-of-pocket costs. $1,000, like for some people that's a lot of money. For some people that feels like not so much. But I want to point out that it's 50% of Medicare beneficiaries are in this bracket. For 50% of them, like they incur costs up to $1,000 in the whole year. And then the different colors, show the different quartiles of the temporal concentration index. And you can see that those with the most concentrated spending of the same amount have much higher probability of having problems paying medical bills. As compared to the second and third quartiles, it's by about 3.5 percentage points, up from a base of about 1.5 percentage point. So that on a relative scale, this is a huge difference. Interestingly, those with the most spread out spending also seem to have slightly higher probability of having problems paying medical bills. And I'll get back to that in a second. I'll now show you, all the other spending levels. It's getting a little more messy here, but there are two reasons for that. One is, we're losing sample size here. 50% of people are in the smallest bracket, while the remaining 50% are in all of these. If you remember from the joint distribution, not all spending levels, or especially the higher spending levels, don't have all kinds of concentration. And but overall, like if we eyeball things here, it still seems to hold that given the amount of out-of-pocket spending, if the amount is highly concentrated in time, people seem to have more of a or higher likelihood of having problems paying medical bills. But this U-shaped pattern seems to, be like preserved in many of these spending brackets, which initially surprised me. I expected to see a monotonic relationship that the more spread out costs are, given the amount, the more affordable they would be. That doesn't seem to be the case. And the way I'm interpreting this is for those with the most spread out costs, that means that they're getting a bill after a bill after a bill after a bill. And in some sense, that can be, a death by a thousand cuts. That it's not necessarily affordability problem. The question doesn't really ask about like, could you afford medical bills? It was, did you experience or did you have problems paying medical bills? And I can see, especially in this older population, it can be overwhelming to be receiving, so many bills constantly. So far that is like the, one surprising finding that we have here so far. So with that, let me move to limitations. I want to be honest about all the limitations that this research or this work in progress has. It's an observational design, so it doesn't allow for causal interpretation. The key outcome, having problems paying medical bills, is self-reported. People can have, people may not remember, especially if they had problems, 9 months, 10 months ago. Again, especially in this older population. Um, the observed spending pattern also is based on Part A and Part B claims. We do not observe Part D claims, prescription drugs, which, in this older, sicker population can be a problem. Like that can change things. Also, we also don't observe dental vision, long-term care spending, all the things that traditional Medicare does not cover. Again, we're studying, people covered by traditional Medicare. So these findings, at least as of now, probably cannot generalize to populations covered by other insurance types, such as Medicare Advantage, Medicaid, military, or commercial. But again, as I said, like that's our next step. We hope to use MAPS data and rerun this analysis on this like more comprehensive or broader sample. But in conclusion, I believe that our paper has two main contributions. One is the metric itself. The metric of temporal concentration can be applied to all kinds of outcomes. It can be, concentration of costs. That's what we're doing here. But it can be temporal concentration of income. It can be temporal concentration of people arriving to the ED. It can be temporal concentration of being exposed to a certain substance. Like in some way, like even water can be deadly if you ingest too much of it all at once. So this metric can be used in not only in economics and health economics, but also in other fields. And from the health policy standpoint, we seem to like we provide some evidence that temporal concentration seems to be a factor of healthcare unaffordability, and therefore it deserves more attention. Because if that is the case, it can be another piece of helpful evidence about how we design health insurance benefits. And with that, I would like to thank you for your attention, and I can't wait to hear your questions, thoughts, and general discussion about what can we do about healthcare affordability in the US.
Thank you so much.
Thank you.
I'm gonna look through our folks here. If you have a question, please put in the chat or use the raise hand function. And while I'm looking for folks with questions, I guess I can ask. I'll kick it off.
Stop sharing here.
So to the, I know there was some. It wasn't the clear kind of stepwise relationship that you thought it would be, but does this give you? Does this support any evidence of the idea that like more predictable healthcare costs are better for patients, as in like if premiums were maybe a little bit higher, but you never had a deductible or a copay, would that be preferable? Or given that we know that people are intimidated by large premiums and will often just choose a smaller premium, is that not the way to go given varying health literacy? What do you think?
Yeah, that's an excellent question. And I, I think what I would like to distinguish is uh, like our measure of temporal concentration, even when costs are spread out, I don't think that necessarily allows us to interpret it as costs being predictable. Like in retrospect, they were spread out, but prospectively, people can still have, in some cases, they probably are predictable. If someone's taking a specific drug every and refills it every month, they probably know what to expect for those costs. But I would still be a little cautious about interchanging the concept of predictability versus costs that are spread out over time. I personally think that predictable costs would be preferable. We know from other parts of economics and especially behavioral economics that people are not very good at dealing with uncertainty and understanding what uncertainty is, what it leads to. And so I want to believe that predictable costs would be better, at least on average. Perhaps not for everyone, but
Vikas, you want to go?
Yeah, can you hear me?
yes.
Great. I'm not sure I captured all of it because I didn't see everything well on my iPhone, but I'm going to ask a very general question, which is, so the neoliberal theory of the case is that out-of-pocket costs provide skin in the game, and that somehow, through some magic formula, is my bias showing? Anyway, uh, through some magic formula, will actually create a market mechanism that provides some discipline to price increases. Setting aside whether or not you believe that, I guess the question I have is we know evidence from the pharmacy literature that abolishing out-of-pocket costs actually improves, medication adherence and a host of number of things, kind of as contravailing evidence to that theory. But I'm just curious whether you've thought about or whether you see any, I don't even know what the right word is, implication or interaction of this new metric that you have, which by the way, I applaud. I think it's excellent to be able to parse things out this way to elucidate what's going on. But whether you have any thoughts about whether there are implications or any uh, relationships between this and that broader question of whether benefit design that includes some out-of-pocket cost could be modified in ways that might test that theory. I personally think it's been disproven, but I'm just curious what you think.
Yeah, I will also try to leave my personal biases aside or preferences. I think it in some way ties to the previous question. Like deductibles make premiums cheap, which makes those plans attractive to people who either have a lot of money or people who don't have a lot of money. But especially for the for those individuals with low incomes, if they choose a high deductible health plan, then they cannot really cover the deductible, and therefore they end up paying for a product that provides no benefits to them. And so even though, like personally, like I'm I am in the privileged population that like when I can choose a high deductible health plan, I do that because I'm knock on wood healthy and I like the low premium, but I don't think high deductible health plans or even like plans with a deductible are the right way to go because they do concentrate a lot of costs upfront, which makes accessing the first visit really difficult, right? And therefore, I believe that plans with copay only perhaps could be like more manageable, more affordable. Of course, there are trade-offs with premiums. I'm aware of that, but that is my take. Like another way to look at this, like if we go beyond what is already available in the market, which copay only plans are, but maybe we could at least restructure healthcare billing in a way that maybe like people receive, one bill per month instead of sometimes 20 different bills from 20 different providers at different points in time. That is like one idea. Maybe one, given that some plans, especially in Part D, right, started offering smoothing of out-of-pocket costs. That's another way to think about this, that this metric can suggest might be, a way forward. Uh, if we really want to revisit previously abandoned concepts such as experience rating in health insurance, that's another way to look at this, perhaps with some caps so that experience rating is not increased to an insane levels for people with expensive conditions such as cancer. But instead of sending unpredictable bills at unpredictable times, maybe slightly increasing the premium the next year might be more manageable financially than what we currently have. Those are some ideas, like my personal take would be like very low copay only plan or no cost sharing at all, but laying out all the ideas.
Got it. Let me just add one thing or follow up, which is, let me make an assertion. I'm not sure, or maybe I'm saying I'm not seeing any way in which this tool and the metric and your findings would have much bearing on the debate about whether copays, deductibles uh, are particularly effective. However, what I do see is that I'm particularly effective for what, of course, is the debate. Like,
Yeah.
it's effective for shifting some cost burden. Yeah, it's perfect. But I guess what I was going to say is, but if you accept the premise that there will be copays and deductibles, because that's what we live in, then I might say your findings do suggest ways of modifying it so that it may not reduce the kind of financially extractive nature of American healthcare, but it would make the risk of falling into debt reduced, or or
Yeah.
or at least make the payments more manageable in a way that is still a financial burden, but maybe not as prone to catastrophic financial events. Is that
Um,
fair?
I think that's absolutely fair. And one other concept that I probably should mention is uh, my other colleagues and I have also put out the idea of changing deductibles from annual to monthly for the very same reason, lower amount, but that resets more frequently, which again would reduce the very large cost burden at the beginning of a policy year. And we saw this like, we started this as a, just like theoretical idea because there's like no reason that a deductible needs to reset every time the Earth finishes its orbit around the sun, right? Like that, there's like no reason for that. Um, CMS has included this idea in its most recent proposed rule for testing for some reason, specifically in catastrophic plans, which I don't think is the right vehicle for this concept, but this idea is out there, and that could also reduce the concentration of costs in time in just one bad month.
Yeah, but the elephant in the room is on the, healthcare provider cost side,
Yeah.
number one. Number two is that the other big elephant in the room is that the healthcare provider in a nonprofit sense is is they have taken advantage of being nonprofit in terms of making wild profits without contributing back to the community and or the patient in any way. I find it a little disheartening that that's where a lot of the problem comes into play, in my opinion,
Mhm.
is that the healthcare provide all the stuff we're talking about now. I mean, I get what you're saying, but the elephant in the room is the healthcare provider. And I'd like for you to, elaborate a little bit on the healthcare provider side and how it plays a role in this whole situation.
That is absolutely a fair point, and I would even like go farther. Like it's not an elephant; it's the Godzilla in the room, right? Like it is like the key problem of affordability is that healthcare prices are incredibly high in the US. Uh, I agree that we should do all we can to reduce those prices. But realistically, I don't see that happening meaningfully. Maybe we can curb or price growth. Maybe we can reduce some prices by a percentage point here and there, but we're not gonna slash them in half. That's not gonna happen, or at least not in, the next 10 years or 20 years. And in the meantime, I believe that modifying insurance benefit design is like, it's a patchwork. I admit, I agree with you. It's not the source of the problem, but it's modifiable and it's actionable. While of course, like we should keep working on reducing healthcare prices. I absolutely agree. But yeah, I just don't see that happening in a meaningful way. Kelsey.
Uh, yeah. Uh, thanks. Thanks very much for the presentation, Michael. Um, we've been looking at hospitals who are signing deals with these like medical credit card companies or what
Mhm.
other types of products that they use. And I feel like they would be very interested in this type of metric.
Mhm.
Like this is better than you getting one huge bill because we can then you space out the bills over time and so forth. Um,
Yeah.
there's a lot of drawbacks to those companies as well in terms of like what protections they have for people and high interest rates and everything. But just wanted to get your thoughts on that sort of process that's happening now.
Um,
Did you do some taping, or is this
It's
by itself? No.
because
in the pure sense of uh, spreading out costs over time, I think that might be a good approach. Of course, we should evaluate whether that is actually the case. Sometimes we find surprising findings when we actually look at the evidence. Um, Of course, I do have some concerns, like like if people take on these medical credit cards and like fail to make those payments, those installments, like what happens then? Um, if that could be just postponing the problem and maybe making the problem even worse. So I would be cautious, but from the pure like spreading out cost over time, sure.
um and one last question because you said you're accessing the MEPS data soon. So if you are stratifying the index by health plan type, like what are you
Um,
hypothesizing?
so maybe let me clarify. The
Mhm,
index is measured at an individual level.
mhm.
Like like we observe each individual's spending pattern over the course of the year. Of course, like if they have any spending, like if they don't have any spending, there's nothing to be concentrated or spread out. But if people have any spending, then we can measure their own individual level or household level um, index of how costs are concentrated. But then we have people grouped in different types of health plans, and generally like different populations, people who are of working age, people who are children, retirees, and so on. And so yeah, I'm curious what we will see there. Generally speaking, I would expect that for younger individuals, overall spending will be likely very concentrated and be more spread out as they grow older, which is what we saw even in the like Medicare population subset. Sorry, now, was there another part of your
No,
question
that was it. I just
yeah.
wanted to hear your
Yeah,
speculation.
I'm curious
Yeah.
what we will see. Yeah.
Any other questions? All right. Well, thank you all so much for coming to this presentation. Check the chat for links to a listserv that Kelsey has created to keep you notified about future webinars. Or if you want to subscribe to our newsletter, go to loudinstitute.org/subscribe. Our next webinar is going to be August 27th, and you can click a link in the chat to register for that. It's free as always. So we'll see you all next time. Thanks so much.
Thank you.
Thank you.
Thank you for having me.